All right, hello guys. Yes, so this is a continuation of our discussion on endocrinology. Okay, so we are done with our hypothyroidism. Okay, now let us move on to your hyperthyroidism. So, yes. By the way, may I just hindi pa pala, we are not yet done. Okay, yeah, baka makalimutan ko pa. Okay, so take note ha that in adults. So hypothyroidism, this is otherwise referred to as your myxedema. Okay, myxedema. Okay. And then in infants, it is otherwise referred, yeah, lagyan natin ng ano, energy ang boses. It is otherwise referred to as your cretinism. So actually, cretinism or um, letter C. Oh my God, I forgot. Congenital. Okay, yes, I'm sorry. Cretinism or congenital hypothyroidism. So this was asked last 2021. Okay. Yes, probably because cretinism or congenital hypothyroidism, this is part of the newborn screening, di ba? And then aside from that, it is also an important disease state. Yes, when it comes to endocrinology. So, yeah, actually, dahil na naman actually, okay, mahilig sila. They like giving diseases which you can correlate, okay, not just in one subject, but in other subjects also. And that's what they like in the board exam. And then aside from that, they also like giving diseases that are prevalent. Yeah, that are currently prevalent. Like, for example, during my time, yes, during my time, acute pancreatitis, or what we refer to as bangungot. I don't know the English of bangungot. Okay, Miss Sim and Ryan, I'm so sorry. But that medically speaking, it is your acute pancreatitis. And so during my time, they asked, yeah, they would usually ask about acute pancreatitis. Okay, so yon. So just yeah, just a tip for the board for your preparation for the board exam. Okay, so when we look at the clinical manifestations of hypothyroidism, so what are the clinical manifestations of hypothyroidism? Okay, so usually, yes, patients with hypothyroidism are obese or fat. Okay, they are obese or fat, primarily because they have low levels of T3 and T4. Remember, what is the function of your T3 and T4? They are important, di ba? Your thyroid hormones are important in metabolism. So, of course, if you have low levels of T3 and T4, so this will decrease also your metabolic rate. So, that's why they are usually obese or fat. Okay, yes. And in relation to this, patients, yes, since they have a low metabolic rate, so they are more susceptible in gaining weight. Okay, gaining weight. Yes. And then apart from that, there is inactivity. Not because they are lazy, but it's hormonal. It's an effect, okay, of the hypothyroid thyroid state, okay, or of their hypothyroid state. Okay, so apart from that, there is also a decrease in appetite. Okay, there is a decrease in wait lang, naantok na. Okay, there is a decrease in appetite. Okay, ayan. So, there will also be cold intolerance. So, remember that one of the ways by which the body is able to, yes, is able to cope up with any, temperature, diba? With the temperature of the environment is via metabolism. Okay, yes. So if, for example, the patient is suffering from hypothyroidism, he or she would usually be intolerant to cold. Okay, so in Tagalog, ginawin siya. Madali siyang maginaw. Diba? Madali siyang ginawin. Ano ba yan? Okay, madali siyang ginawin. Okay, so cold intolerance. Alright? Ayan. So those are the clinical manifestations of your hypothyroidism. So now let us move on to our hyperthyroidism. So again, if you're going to look at the term hyperthyroidism, o, diba? Hyper would indicate an increase. Okay, increase in the hormone, yes, T3 and T4. Okay, yeah, so that's why it is hyperthyroidism. So again, what organ is affected? Diba? What organ is affected in the case of your primary hypothyroidism? Okay, so again, since it is primary, so the one that is affected is your thyroid gland. Okay, and since it is affected or since it is defective, yes, since it is the one that is defective, so this will now lead to an increase in your T3 and T4. Okay, ayan. There is an abnormality in your thyroid gland which makes it produce too much of your T3 and your T4. Okay. Is there something wrong with our anterior pituitary gland? So, yes, very good. Nasusundan na niya. Okay. So, there is nothing wrong with your anterior pituitary gland. So, that's why as a response, okay, as a normal response of your anterior pituitary gland to increased levels of your thyroid hormone, what will be the effect? So your anterior pituitary gland will secrete less of your TSH because your T3 and T4 levels are already elevated. Diba? So if your anterior pituitary gland will continue to release the same amount of TSH, then your T3 and T4 will be further increased. Tama? Okay. And so the normal response of your anterior pituitary gland is that there will be a decrease in the secretion of your TSH. Okay, so again, what will happen first or what is the predicate in this case? So the predicate is that there is something wrong with your thyroid gland which will now affect, di ba, your anterior pituitary gland or which will now lead to a decrease in the synthesis and release of your TSH by your anterior pituitary. Okay, ayan. So we have your primary hyperthyroidism. Okay, so next we have our secondary hyperthyroidism. So in secondary hyperthyroidism, remember that your thyroid gland is working properly. Okay, so there is nothing wrong with your thyroid gland. Okay, so what is the what is the what is defective, rather what is abnormal or what is defective is your anterior pituitary gland. Okay, so in particular, your anterior pituitary gland secretes too much of your TSH. Okay, so what will be the effect of an increase in your TSH? Okay, what will be the effect of an increase in your TSH? The effect would be, of course, your TSH will stimulate, diba, the release now of your T3 and T4. Okay, ayan. So it will stimulate the release of your T3 and T4. Okay, why is there a hyperthyroidism? Because there's an abnormality involving your anterior pituitary gland. Okay, so yan. So I do hope that everything is clear. And if we are going to look at the clinical manifestations of your, if you're going to look at the clinical manifestations of your hyperthyroidism, so it is just the opposite of the clinical manifestations of your hypothyroidism. So in hyperthyroidism, there is an increase in the metabolism, okay, of the individual, leading to the following. So you would be, or patients with hyperthyroidism will be thin or slim. Okay, so this is again related to the weight loss that is happening in the patient. Okay, ayan. So if there is inactivity in your hypothyroidism, in your hyperthyroidism, so there is hyperactivity. So again, this is not because hyperactive talaga yung pasyente, but it is an effect, okay, of increase in your T3 and T4. So there will also be an increase in appetite. Okay, there will also be an increase in appetite. Okay, increase in appetite. And then in contrast to the cold intolerance that is manifested by hypothyroid patients, there is naman heat intolerance. Okay, there is heat intolerance in hyperthyroidism. So this is also related to the increase in metabolic rate. So remember that when you undergo metabolism, okay, when your cells undergo the process of metabolism, one of the byproducts, okay, of metabolic pathways would be the generation of heat, right? The generation of heat. So since there is an increase in the metabolic rate, so there would also be more heat that is produced in the case of hyperthyroid individuals. Okay, ayan. So another important, anong pangalan nito? Another important um, topic that we have to discuss in the case of your thyroid gland or thyroid states would be your autoimmune disorders. Okay, your autoimmune disorders. Okay, so again, Hashimoto's and your Graves' disease. So there are two subjects in which you may be able to encounter it. So we have your clinical chemistry, and then of course the other one is your immunology and serology. Okay, so in the case of your CC, in the case of clinical chemistry, they have asked about the autoantibodies, okay, of in your Hashimoto's and your Graves, as well as, okay, as well as the type of thyroid state that is, yeah, that is seen in your Hashimoto's and your Graves disease. Okay, so first let us discuss what are the autoantibodies, because this may be asked not just in CC but in your immunology and serology also. Okay, so the following antibodies are seen in your Hashimoto's disease. We have your anti-microsomal antibody, and then we have your anti-thyroglobulin antibody. And then kindly add one more. Okay, one more antibody is your antibody, anti-thyroid peroxidase antibody. Or in some other books, they refer to it as thyroid peroxidase antibody. Okay, so these are the designations of your anti-thyroid peroxidase or thyroid peroxidase antibody. Okay, so remember that in the case or in the production of your thyroid hormones, your thyroglobulin is a very important, diba? It's a very important precursor material for the synthesis of your T3 and T4. So since your autoantibodies attack, diba, attack certain structures or certain cells in your body, so that is what your anti-thyroglobulin antibody do. Okay, so your anti-thyroglobulin antibody will attack your thyroglobulin, which is the precursor material for your T3 and T4. So if you don't have thyroglobulin, so of course this will affect, diba, the production of your T3 and your T4. Okay, so in the case naman of your thyroid peroxidase antibody, so from the term itself, it attacks the enzyme thyroid peroxidase. So again, thyroid peroxidase is an important enzyme in the synthesis of your thyroid hormones. So if you don't have the enzyme, then you will not be able to carry out the process of producing your thyroid hormones. Thereby, yes, in Hashimoto's thyroiditis, this is a hypothyroid state. So that you will remember it better, Hashimoto, 'di ba? Hashimoto, hypo, okay? Hashimoto, hypo, okay? Hypothyroid state. Okay, another, we have your Graves disease. Okay, so in your Graves disease, there is a receptor which we refer to as your anti-TSH receptor. In other references, we call it your TSH receptor antibody. Okay, yes. So since it attacks your TSH receptor, actually, this is a very unique antibody in the sense that it will not attack the receptor really. What will it do is that it will mimic, okay? This antibody mimics your TSH. Ginagaya niya si TSH. Gaya-gaya siya. Mimic-mimic siya. Okay, it mimics your TSH. Okay, so again, class, what is the role of our TSH? The role of our TSH is to stimulate, di ba? Thyroid hormone production. Okay, thyroid hormone production. So, if your anti-TSH, okay, if your anti-TSH receptor antibody mimics your TSH, then this antibody will also stimulate thyroid hormone production. Okay, yes, yes. So what will happen? There will be a hyperthyroid state. Okay, yes. So there will be a hyperthyroid state. Okay, ayan. So it will bind with your TSH receptor. It will stimulate or activate your TSH receptor, thereby, yes, stimulating your thyroid gland to produce more thyroid hormones. All right, ayan. So actually, yes, if you are going to look at the thyroid profile of our patients, di ba? What will differentiate your primary from your secondary hypo or hyperthyroidism is your TSH. Okay, so that's why TSH is considered to be the most useful test for assessing thyroid function. Okay, yan. So you are able to determine which organ or which gland is affected in a hypothyroid state or in your hyperthyroid state. Okay? Before, ang natanong with regards, actually laging tinatanong yan. So they would usually give a thyroid profile and it would usually be your T3, T3, T4, and then your TSH. So that's why it's important to understand. Okay? Sorry. It's important to understand how you're supposed to interpret your thyroid profile. Okay, so another recall question is in the case of your cretinism. So I think parang which of the following is not associated with cretinism? Yes, and then the answer I believe is thyroiditis. Yeah, because I have read that in cretinism or in congenital hypothyroidism, um, there is a possibility that the thyroid gland itself is not fully developed. So how can you have thyroiditis if the thyroid gland itself is not fully developed? So when we say thyroiditis, it involves inflammation of your thyroid gland. Okay, yes. I have tried my best to look for the answer to that. But yeah, the best answer among the given choices, if I'm not mistaken, the choices were cretinism, um, parang growth, parang parang there is a decrease or abnormality in growth, development. Ano pa ba? I forgot. Okay, but anyway, I'll try to look for it and then I will share it na lang in our pre-ratio. Pre-ratio. Yeah, pre-exam ratio. Okay, ayan. Ayan. Okay, move on. Malapit na to class. Yeah, sure. Talaga. Okay. Next, we have your parathyroid gland. So, um, it's a favorite. Yeah, parathyroid gland is a favorite. There were two questions. I have two. How many recall questions do I have? Two. I have two recall questions when it comes to your parathyroid gland. Okay, actually not really two, but siguro three. Yeah, I forgot now. Okay, but anyway, I will mention it. Okay, so the next gland that we will be discussing is your parathyroid gland. So your parathyroid gland is of course important for calcium metabolism. Okay, calcium metabolism or no, not calcium metabolism, calcium homeostasis. Okay, calcium. You know what? Favorite nila ang calcium. Um, la, tama pa ba yung spelling ko? Homeostasis. Okay, yes, calcium homeostasis or maintaining the normal calcium levels, particularly in blood. Okay, so first, there are actually several substances which are important in maintaining normal calcium homeostasis. Okay, so first we have your parathyroid hormone. So remember that your parathyroid hormone, so this is secreted, of course, by your parathyroid gland. Okay, ayan. So the stimulus for your PTH or parathyroid hormone, just like what I have mentioned a while back, would be low blood calcium levels. Okay, so this will be detected by the receptors present in the parathyroid gland itself. And of course, this will stimulate now the release of your parathyroid hormone. Okay, so your parathyroid hormone will work by several ways. Okay, one way by which your parathyroid hormone increases your blood calcium levels is to promote, diba? Um, wait, promote bone resorption. Okay, so guys, when we say bone resorption, this is equivalent or this is otherwise referred to as bone. Alam ko itong si Noel, Anafi ko to eh. Hindi natin to diniscuss. Hindi natin to discuss. Okay. Bone resorption is otherwise referred to as bone, okay, dissolution. Because sometimes they will not use the term bone resorption. Bone dissolution or bone destruction. Okay, yes. So please do not misunderstand bone destruction, ha? Because you really need to destroy the bone in order for you to release calcium. There is a need to destroy, particularly the bone matrix, diba? That contains your hydroxyapatite. Hydroxyapatite is important not just for the structure of your bones but also for the storage of your calcium. Okay, yes. So once your body needs calcium in blood, so of course, what will you tap would be the reserve, 'di ba? Ganun naman lagi. If there is a need for something, you tap or you get, okay? You get the needed amount from your reserves. And in the case of your calcium, the reserve is your bone matrix in the form of your hydroxyapatite. Okay? So in addition to promoting bone resorption, yes, in addition to promoting bone resorption, your parathyroid hormone will also stimulate, okay, the conversion of your calcitriol from its inactive form, which is your vitamin D. So vitamin D, therefore, is the inactive form of your calcitriol. Okay? Or, if I'm not mistaken, this was already asked. Um, what is the active form of vitamin D? It's your calcitriol. Okay, so your calcitriol, it will be the one which will be directly involved in conserving calcium ions from or in your kidneys. So that means, okay, it will prevent, diba, the excretion of calcium ions via your urine. So that's one. So apart from that, your calcitriol will also be the one that will be directly involved in the intestinal absorption of your calcium. Okay, ayan. However, yes, kasi this has been asked in the board exam. So, if for example, calcitriol is not among the given choices, say for example, which of the following hormones increases the intestinal absorption of calcium? So, of course, the best answer is your calcitriol. However, if calcitriol is not among the given choices, then you look for parathyroid hormone. Okay, because even if it does not directly increase your intestinal absorption, it is the one, okay, it is the one which will stimulate the activation of your vitamin D into calcitriol. Okay, ayan. So thereby, if calcitriol prevents the excretion of calcium and stimulates the absorption of calcium from the diet, calcitriol will therefore increase also your blood calcium levels. Okay, yes. Another recall question is, sometimes they would also ask, wait lang ha. Okay. Lagay ko lang dito, active form. Okay, so this is the active form of vitamin D. Okay. Sometimes in the board, they would even include your vitamin D. Okay, so ganito. Usually, at ito tinanong na nila ito. So, which of the following verbatim, this is verbatim, coming from a recall question given by one of our examinees. So which of the following is not a hormone? Lagay doon. Which of the following is not a hormone that increases blood, okay, calcium levels, right? And then the choices are parathyroid hormone, okay, calcitriol, ayan, we also have calcitonin, and then the last one we have vitamin D. So what is the best answer? Which of the following is not a hormone that increases blood calcium levels? So the correct answer class, okay, the correct answer class is calcitonin. Okay, why? Because take note that calcitonin is a hormone that will decrease your blood calcium levels. Okay, so in particular, your calcitonin, this is not produced by your parathyroid hormone. So it is actually produced by the para. Okay, we have the para follicular cells of your thyroid gland. Okay, ayan. So, parafollicular cells of your thyroid gland are otherwise referred to as your C cells. Okay, ayan. All right, your C cells. And then another recall question for your calcitonin. Which of the following is a marker for thyroid medullary? Medullary thyroid carcinoma. Okay, so the correct answer is your calcitonin. Okay, ayan. Ma'am, let's go back to the question. Okay, let's go back to the question. All right. So in the question, it says there, ma'am, in the question, it says there, not a hormone. Okay, yeah, that's correct. Not a hormone. Is vitamin D a hormone? It is. Okay, yes. You can read your references. I just forgot who mentioned it. I think it was Bishop who mentioned that vitamin D, even if we refer to it as a vitamin, it is actually a hormone. Okay? It just so happened na we have been using the term vitamin D for so long that it's already inconvenient to change the name of your vitamin D. Okay, but it is a hormone. So one analogy that I can probably give to you is water. Diba? Is water the chemical name of water? No, it's dihydrogen oxide. Diba? H2O, dihydrogen oxide. That's the chemical name of water. But we have been using the term water for so long already that it will be inconvenient to change it to dihydrogen oxide. Okay, so same is true in the case of your vitamin D. Okay, it will be inconvenient to change the name of your vitamin D. All right, but take note, it is a hormone. Okay, it is a hormone po. Do not forget. So please, ginugulo lang nila kayo. They are just getting into your nerves. Okay, all right. So it kaya nila nilagay yung not dyan eh. That's why they put the word not there so that you will be confused in the boards. But do not be confused because vitamin D is a hormone. Siyempre, di ba? The first thing that examinees will notice is that, oh, it's a vitamin. So it's probably not a hormone, but it is. Okay? Ayan. Alright. So now let us move on to another endocrine gland, and that is your adrenal glands. If I'm not mistaken, this the no. Oh, wait, still more glands. Okay, so we have your adrenal glands. All right. So take note that your adrenal glands, yes, so they are pyramid, yeah, pyramid in shape. Yes, and they are located above your renal, your kidneys. Okay, pyramid shaped glands located above your kidneys. Okay, and there are two areas present in your adrenal glands. So first we have your cortex or the cortical layer, which is the outer layer, and then we have your medulla, which is the inner layer. Okay, so your adrenal gland, particularly the cortical layer, is divided into three zones. Okay, we have your zona glomerulosa, otherwise referred to as your G zone, zona fasciculata, otherwise referred to as your F zone, and then zona reticularis, otherwise referred to as your R zone. Okay, ayan. Okay, so first we have your zona glomerulosa. Okay, your zona glomerulosa, this is important. Yes, this is the area or the zone that produces your mineralocorticoids. Of course, the most popular of your mineralocorticoids is your aldosterone. They asked about aldosterone before. So please do not forget that your aldosterone, so this is, okay, bakit siya tinawag na mineralocorticoid? Diba? Why do they refer to it as a mineralocorticoid? This is because it is involved in the reabsorption of a mineral, diba? It is involved in the reabsorption of a mineral, okay? And what is this mineral? So that is your sodium. Okay, ayan. So remember that the the secretion of your aldosterone. So this is induced by your RAAS, your renin aldosterone angiotensin system, right? Okay, yes. So it will promote sodium reabsorption. Okay. Another, we have your glucocorticoids from your zona fasciculata. And of course, the anong pangalan to? Representative hormone of your glucocorticoids, we have your cortisol. Okay, yes, we have your cortisol. Your cortisol class, this is otherwise referred to as your stress hormone, but take note that it is not the first one to respond to stress. Okay, why? Because the body responds to stress by releasing cortisol within minutes. Okay, yes, within minutes. You can read about your cortisol, particularly your adrenal gland assessment from your bishop. So I repeat, endocrinology, I highly recommend bishop. Okay, so even if we refer to it as a stress hormone, it is not the first responder. Uh, okay, tama. It is not the first responder to stress because it responds within minutes. All right. So take note also that your cortisol, okay, take note, it is a hyperglycemic agent and it will increase your blood glucose level. Remember, when your body is stressed, you need more energy. You need to feed your cells more. And how do you feed your cells? By providing more glucose. Okay, and I think this is probably the reason why when we are stressed, we do stress eating, right? Yeah, we do stress eating because your body needs more glucose in order to combat the stress, diba? In order to combat the stress. Okay, and then another, we have your zona reticularis. Yes, your zona reticularis. So this is naman important in sulfating. This is an area that is involved in the sulfation. Okay. Sulfates. So it adds sulfate. Sulfates your DHEA, which is considered to be a weak androgen. Okay, so DHEA is your dihydroepiandrosterone. Okay, dihydroepiandrosterone, which is a weak androgen. So sulfation of your DHEA into DHEAS happens in your zona reticular. All right, ayan. So next we have your medulla. Your medulla class, so this is sorry, this is naman responsible for the release of your catecholamines. So when we talk about your catecholamines, we are referring to your epinephrine and norepinephrine. Okay, so epinephrine and your norepinephrine. So take note that your catecholamines, they are regarded as first responders, okay, to stress. Yan. So they are regarded as first responders to stress. They respond to stress within seconds. Okay, yes. All right. You know, this was asked in 2021 board exam. First responder to stress. The correct answer, catecholamine. Where did they get the term first responder? It's from Bishop. You can check it. First responder. Okay, to stress catecholamine. They respond within seconds. Okay, yes. So they respond within seconds. Yan. So another naman classic recall question when in relation to your epinephrine and norepinephrine is the metabolite. Okay, this is a classic question because even during my time, metabolite of your epinephrine and your epinephrine and your norepinephrine has been highlighted, or yeah, has been highlighted even during my time. Okay, so you can just guess how long ago was that. So metabolite of your catecholamine is your VMA or your vanillyl mandelic acid. Okay, so we have VMA or your vanillyl mandelic acid. So do not forget, classic question. Recent question, first responders. So those are the things that you have to remember in the case of your adrenal glands. So now let us move on to your pancreas. So actually, the reason why I included pancreas is again, um, it has been highlighted even during my time. Okay. So take note again, your pancreas, it has both or it is both classified as an exocrine gland and an endocrine gland. So as an exocrine gland, it is responsible in secreting your enzymes of digestion. Particularly, we are talking about your pancreatic lipase and pancreatic amylase, which are both important in the diagnosis of your acute pancreatitis. So actually, the bangungot thing, class, is, yeah, it's real. Yes, and 'di ba sabi nila, you will have bangungot or acute pancreatitis if you are going to eat a lot for dinner, right? A lot during dinner. And then what happens is that your pancreas, it becomes inflamed because uh, it has a higher workload if you are going to eat too much, okay, during dinner. Remember that after eating, what do? You sleep. Okay, so digestion of your food becomes even harder, okay, when you are asleep, right? Ayan. So that's why there is an overload on your pancreas, in the sense that it has to produce more of your enzymes of digestion. And this can lead to acute pancreatitis. Okay, yeah. So like fast, yes, fast inflammation, di ba? Ano ba yun? Fast inflammation. Di ba acute nga eh, okay, pancreatitis. Your pancreas will become inflamed because of a higher workload, a higher need for it to higher demand. Yes, a higher demand for it to produce your lipase and amylase to digest what you have eaten, okay, during dinner. Ayan. So, also take note that your pancreas, it is also an endocrine gland because it is capable of producing the following hormones. We have your insulin, your glucagon, and your somatostatin. In order for me to easily memorize your insulin, glucagon, and somatostatin, as well as the cells that produce them, I usually arrange them alphabetically. Okay, so of course, glucagon first, and then insulin, and then somatostatin. Okay, so glucagon, so this is produced by your alpha cells, right, of the islets of Langerhans. Your insulin, on the other hand, so this is produced by your beta cells. And then your somatostatin, this is produced by your delta cells. So you just arrange them alphabetically, and then you arrange also the cells alphabetically. So how easy you can memorize or remember your pancreatic hormones and the cells necessary, or yeah, the cells necessary to produce them, or responsible rather for their production. So this is the last one. Yes, so 50 minutes ulit. Okay, so we have your sex hormones. So again, just like what I have mentioned, sex hormones, it is included as a separate, diba, as a separate mm, entity, entity talaga, okay, as a separate topic, okay, under your endocrinology, okay. So sometimes I would just ask what is the most potent, yeah, like that, okay. So no, anong pangalan nun, no bashing, hindi, no pressure. Okay, no pressure. So take note that the most potent male sex hormone is your testosterone. Okay, it's your testosterone. Yan. Your estrogen naman, remember that there are three forms of estrogen. And then, of course, the most potent among the different estrogens is your estradiol. So it is the most potent female sex hormone. Okay, your estrone, it has a significance in the case of menopausal women. Okay, your estriol, on the other hand, so the primary source of this hormone, especially during pregnancy, is your placenta together with your progesterone. Okay, so take note that your placenta at the beginning of pregnancy, it is not fully developed. So that's why if you're going to look at the levels of estriol, okay, it is significantly increased in second and third trimester of pregnancy together with your progesterone. Okay, so di ba, what hormone do we assay or do we detect during the first trimester? It's your human chorionic gonadotropin. Ayan, okay. We have your human chorionic gonadotropin. All right. And then what else? Actually, I have checked this in both Bishop and in both Bishop and Henry. Okay, because I'm not sure if it's still the one that is being discussed during review. Ayan, estradiol, it is the most potent, not just for non-pregnant women or females, but also in pregnant females. Okay, yes. That's why you have to be careful when you are asked for the most potent or the primary. Yes, the primary hormone. So the way I understand it, the most potent is still your estradiol during pregnancy. However, the primary hormone is your estriol. Okay, in particular, your estriol is significantly increased. Okay, in the case of pregnant women. Yes, ayan. Significant kasi yung increase niya in pregnancy as compared to before or to non-pregnant states. Okay, or in non-pregnant women. All right, so that's why it is considered to be the primary hormone. Okay, associated with pregnancy or associated with pregnant women, we have your estriol. Diba? So significant your estriol during pregnancy that we use it in order for us to detect pregnancy. Okay? So please do not misunderstand. Most potent, what if the question goes like this? Most potent hormone during pregnancy. What is the answer? Estradiol. Okay? Primary hormone associated with pregnancy, estriol. Okay, yes. So please, okay, do not misunderstand. All right. So hormone that is detected during the first trimester, human chorionic gonadotropin or your HC. Okay, do not forget. A hormone that is increased in second and third trimester, progesterone and your estriol. Okay, yes. May I just also add, remember kasi that your HCG, it is merely produced as an alternative to your progesterone. So the function of your human chorionic gonadotropin is to maintain the vascularization of your uterine wall. Ma'am, is that important during pregnancy? But of course, because remember, the baby cannot provide its own nutrients, diba? The baby cannot remove its own, cannot remove the metabolic wastes that it produce, that no, not it, that the baby, the fetus produces as it grows or as it develops. So how can the baby inside get rid of these toxins or of these waste products? It's via the mother's circulation. Okay, how can the baby provide for its nutrients? Again, it gets its nutrient from the mother. Diba? From the mother, yeah. Okay. So, the vascularization or the presence of blood vessels in the uterine wall is very important so that the baby will remain to be viable. The baby will have a normal development. Okay? So during the first trimester, what maintains the integrity of your or of your blood vessels in the uterine wall is your HCG, because your placenta is not yet fully developed during the first trimester. you have to wait until the second trimester and the third trimester before you have to wait until it is your second trimester before the placenta becomes fully developed and it is able to secrete or to produce and secrete adequate amounts of progesterone, okay, as well as estrogen. All right. So once the levels of progesterone is established, that is the time that you don't need your HCG anymore. That's why if you're going to look at the levels of your HCG, it peaks during the first trimester and then it goes down, okay, as the pregnancy progresses. Diba? Okay, ayan. Yes, so HCG, clinical significance, it is used for pregnancy for the detection of your trisomy 21, okay, trisomy 21, malignancies like your H-mole, diba? H-mole, and then ectopic pregnancy, trisomy 18, and then trisomy 13. So these are the applications of HCG detection. Okay, ayan. Alright. Oh, malapit na guys. And then the last, this is the last one. Yeah, this is the last one for our endocrinology. Okay, so yes, this is the end of part 2 of your endocrinology. So bye again. Bye again.